Well, welcome, everyone. Before we get started with our program today, our government task leader for the National Home Health Campaign, Cynthia Pammon, would like to make a few comments and remarks. Cynthia? Cynthia, are you with us?
Dave, it looks like Cynthia is mute, or she hasn't called into the phone yet. So.
Okay. All right. Well, let's move along then, and we can pull Cynthia in at the end of the webinar. As we are all aware, this issue of being able to impact avoidable, unnecessary hospital readmissions is an issue many people are trying to tackle. We are pleased to have with us today Dr. Jane Brock, who, with her team from the Colorado QIO, are responsible for guiding the 14 QIOs that are awarded the unique contracts from CMS to work on selected communities within each of their states to address the issue of reducing 30-day avoidable hospital readmissions for Medicare beneficiaries by improving transitions across healthcare settings. Jane and her team have been the guiding force with assisting these 14 states in their groundbreaking work. Dr. Brock has been gracious enough to break away from her busy schedule to share with us some of what has been learned during the first 2 years of this project. Obviously, these communities include providers from hospitals, nursing homes, physician offices, and home care. Following Dr. Brock's presentation, we will have some time for questions and answers. We would ask that you, as you generate your questions, you forward them to hhqi@wvmi.org. We will utilize this format then to handle questions given the large numbers of participants on the call today. Dr. Brock is the Chief Medical Officer for the Colorado Foundation for Medical Care, which is the QIO, or Quality Improvement Organization, in Colorado. She brings with her a resume that includes not only a very prestigious educational background, but also a list of numerous accomplishments. I think you will enjoy her very down-to-earth and practical style of presenting over the next 30 to 40 minutes. And without further delay, I'd like to introduce our speaker today, Dr. Jane Brock.
Thank you, Dave. What a nice introduction. Well, let me just say it's my pleasure to talk to you all today. I think we all know that there's a tremendous role, obviously, for home health in improving the situation that we have today, well, almost the non-situation we have today in terms of quality transitional care. So it's been a very welcome exercise for me to go through what I think is the role of home health, and where I would think that home health agencies, how I would advise them where they should go to become an increasing part of this. I believe that within the ACA, the Medicare Reform Bill, there will be enhanced opportunities for home health agencies to be taking a central role. So let's see. Oh, I'm sorry. I'm going to need help with how to advance this slide.
Dr. Brock, if you want, if you have it on full screen view.
Yes, I
at
do.
The bottom,
over here.
With the small thing, you can go, just hit that arrow button.
Okay, this one?
The one that has 01 beside it right now.
Yeah.
There's an arrow button that says go to the next page. You can click that. Does that allow you to advance?
Here we are. Oh, got it. Thank you.
So
anyway, what I wanted to talk about today is I wanted to give a brief overview of the QIO care transition theme, just so that everyone understands the work we've been doing for the last couple of years. One of our key lessons learned is that community is really key to solving the problem of transitional care, as well as reducing unplanned 30-day hospital readmissions, which is our key measure of success. And then I wanted to give some examples of the role that home health agencies are taking within some of the communities in the theme. So the care transitions theme, the basic structure for the care transitions theme is that each site, each funded QIO applied to do this work by defining a community of beneficiaries based on their geographic location of residence. So we defined a community of zip codes and assessed the readmission rates and the care patterns leading to readmissions within the community, meaning as it affected fee-for-service Medicare beneficiaries that lived in this place. So QIOs have access to claims data, so we could identify the service patterns that were associated with readmission and identify the participants, the medical services providers that were involved in care patterns that resulted in readmissions, so that we could recruit and convene providers and whoever. In most of the projects, we have gone well beyond medical service providers to look at community-based service providers and others who deliver supportive services to elderly and often non-elderly within the identified community. The goal of the work is to reduce unplanned 30-day hospital readmissions for the population, not any given provider, but for the population. And we were required by contract to use evidence-based tools and interventions. So when I talk about defining a community, this is how we thought about it in terms of looking at claims. So if you take a population of fee-for-service Medicare beneficiaries living in a specific place that you are interested in, and then you overlap that with hospital discharges and start to look at the hospitals that are involved in readmissions and the care patterns between hospital discharge and readmissions, you come up with a target population comprised of the fee-for-service beneficiaries in the area overlapped with a finite group of medical services providers. So this is just a schematic of how we think about what I mean when I say in the future through this presentation by community. I mean a population of people and the medical services providers that are largely involved in delivering services to them that are associated with patterns of hospital readmission. So I wanted to be clear in that when I talk about the role of home health, I just wanted to give this is a fake example of what we call a proportion transitions table. So within our data, not only can we tell which service patterns, general patterns, and sometimes they're quite complicated. I'm sure everybody on this call knows that. People are discharged from the hospital, they go to a SNF, they're discharged with home health services, they see their physician, and they go back to the hospital. So, you know, that's not an uncommon care pattern. So often care patterns are quite complicated. But in general, when you look at Medicare claims, you can kind of pair up service providers as senders of discharges, so you know, hospitals certainly send a lot, and then receivers. So I want to be clear that every transition, when I say the word transition, we view every transition as having two sides. So within our data, what we did is we would look at say, Hospital 1, who typically functions as a sender, to look at who receives their who's on the other side of that sending activity. So the transition has two sides. And so this is fake data, but, you know, as would be expected, home is a primary receiver often. I have to say within our claims, we're not always 100% certain of whether or not there is a home health agency involved in every discharge to home. But in general, we can look at the claims and kind of look at what we think are likely to be pairs of senders and receivers that are more involved in readmissions than not. So in terms of what interventions the QIOs are doing, we really have a great deal of flexibility within our contract. So as I always say, whatever it takes. Now, the interventions that we have to use need to be evidence-based, and the 14 communities that are engaged in this work are using all of these interventions to more or less degree, and often using adaptations of these interventions in order to take advantage of projects going forward among multiple providers that can contribute to each other. So the most frequent intervention being used right now within the QIOs doing this work is the care transitions intervention, which is Eric Coleman's coaching intervention. There's been a lot of interest in the CMS discharge checklist. If people are not familiar with this, please feel free to email me, or you can email the team in Pennsylvania, and we can certainly talk a lot more about this and link you up with the resources. It's on the Medicare websites, but it's a discharge checklist that CMS designed to go from providers to patients. It's a direct to patients discharge checklist for what they should be prepared to think about at the time that they're thinking about discharge. This is the only intervention that's being used for which there's not yet an evidence base, but it's certainly in line with a lot of other interventions around which there is a great deal of evidence base, and that is incorporating patients into preparation for their own discharge. The Interact intervention is specific to the relationship between hospitals and nursing homes. With regard to hospitalization behavior, a great deal of the Interact toolkit depends on standardized communication and well, a lot around standardized communication. The transitional care nursing model is Mary Naylor's model from the University of Pennsylvania. There are a couple of QIOs that are implementing various components of this model, both with regard to hospital discharges as well as with regard to SNF discharges. Project RED, with the re-engineered discharge from Brian Jack at University of Boston, is being used in several communities. Project Boost from the Society of Hospital Medicine, which is a hospitalist to discharge planner, quality improvement support infrastructure, and then of course the best practices intervention packages from the Home Health Quality Campaign, and elements of the Transforming Care at the Bedside Guide to a Quality Hospital Discharge, which is an IHI product. So all of these are being widely used, components of them in some cases, full models of some in some cases, but I would say these are the majority of interventions on which these communities are focusing their efforts. So the 14 QIOs and target communities that are currently engaged in this work are on this map. So I'll leave this for future reference. So among these communities, of course, it varies because providers kind of come into the work and make changes and then sometimes become less of a prominent participant in the work with regard to the local communities. But in general, we think there's about 70 hospitals, 277 skilled nursing facilities, 316 home health agencies, and 89 other provider types that are active participants in this work across the 14 communities. So the projects target 666 zip codes and about 1.25 million Medicare beneficiaries. So the goal of this is to reduce unplanned hospital readmissions by a little over 2,700, which would be 2% of the original readmissions at the time this project started. So I just wanted to summarize as briefly as I can some of the key components of what we are learning, and a lot of what we are learning is the power of building a community of practice around the issue of hospital readmissions. So the way I always frame this is to ask why 5 times, and I'm only going to ask it 3 times in these slides, but you know, if you think about just conceptually, why do hospitals have unwanted readmissions? The easiest answer, and the answer that's quite obvious at the provider-patient interface, is that we have chaotic practices for medication management. We have chaotic practices for medication management within single settings, and across settings, of course, you know, it's worse. We don't have effective patient engagement strategies that are routinely used, standardized and measured, and we have unreliable ways of ensuring rational follow-up patterns for patients to take following a hospital discharge. So this is what I call the answer to the first why, the problems that you see at the patient-provider interface. So there's a huge amount of literature on this, but in general, I think you can boil it down to these 3 reasons. But if you ask why again, well, why do we have these problems? You know, we have in some ways the most sophisticated medical system in the world. How is it that we just can't solve this? And it's really because we've not designed systems that encourage any of these 3 things. So in general, despite the fact that we know, and certainly every provider involved in the care chain knows, that they share lots of patients with other providers, and that they even likely know exactly which providers they share a lot of patients with. But even so, we seldom have what would be a standard and known, reliable, measured, and accountable process the way we would have in any other industry. So I think of this often, I love the Toyota production system, and I think of this as kind of a classic supply chain problem, and we just don't have a system where we've ever thought about applying the principles of supply chain management to the movement of patients through multiple provider settings. The second thing is we have unreliable information transfer. Now there's a great deal of work and money being directed at solving this problem with regards to standards around health information exchange and requirements around data elements to exchange them. So my belief is this is getting better and will get better quickly over the next few years, but as of now, we really don't have that in most communities, an absolutely reliable place to exchange clinical information. And then we don't have the system level support for patient activation during transfers. When I say patient, I mean patient and family activation. So as I'm sure nobody is more aware of than a home health agency, often it's the patient themselves and their family that's really kind of the primary caregiver, and we have not systematized proper engagement of those caregivers in general within our medical care infrastructure. So we don't have the system support for these elements, but I think you have to ask why again. Well, why don't we have system support? Why is this so difficult? Why are we still wrestling with these issues? And the answer that we've come up with, and that I think that most of the 14 communities would agree with, is that, in general, we've never established community infrastructure for achieving common goals. So it's nice to talk about national standards, and I think, well, it's imperative to talk about national standards, but in general, I think that what we're discovering is when you get right down to it, you have this local population, you have a finite number of providers who serve most of their needs, but we've never thought about establishing sort of a regional community infrastructure for how that should go forward in terms of rational care design, delivery, and accountability. So these elements of unreliable system support are what we are calling within this theme the drivers of hospital readmissions. So these are the when the QIOs and their community participants have gone forward to try to solve the problem of unplanned readmissions, in general, most of the activities end up being focused at these three things, these drivers of readmission. So a lot of the work has gone around trying to create standard known process, trying to solve the issues with unreliable clinical information transfer, and trying to incorporate intentional elements of support for patients and families during the times of transfers. So the intervention packages that I mentioned earlier, the well-known evidence-based interventions that most of the communities are using actually can be sorted into these, basically into these three things. So if you're within a community that really has no idea where to start, and I actually think that community probably doesn't exist, you can look at any of these intervention packages and think about which problems that you feel you most need to solve. Do we need a standard known process? So I think Project Boost is exactly designed to create that kind of an interface around hospital discharge. If you really need patient activation, the CMS discharge checklist and the care transitions intervention are designed exactly to do that. So, I think I again leave this slide for your reference. In addition, we have on our website CMS's table of interventions which have evidence behind them that they are associated with reduction in hospital readmissions. So you can look at our website. This article was originally published in the Remington Report, but is available at cfmc.org/care transitions. So when you think about it, we know what to do. We have these robust interventions. We know how to measure them. We know what we need to do. We can sort down out into a project that takes activity directed at these specific problems, and I think there's general knowledge that is the case. But when it comes right down to it, I think what we're not very good at thinking about in medical services delivery is the partnership problem, what I call the partnership problem. So, it's kind of a classic partnership problem. You have to form some kind of partnership arrangement with entities that not only are you not natural partners with, but you might actually be competitors with. So when you think about the way patients are moving, so if discharges, you come back from the physician office, you come back from your home, by self-referral, or from the home health nurse, you come back from the SNF. All of those are a two-way problem where they sent them to you, you're sending them back. And if you don't have any kind of a sense of partnership or actual formalized partnership, it's kind of difficult to start looking at what exactly you need to do to solve that problem. And when you think about how the information should flow, it gets orders of magnitude more complicated. Certainly every facility has a medical director, so physician-to-physician communication can be quite impenetrable. If you don't practice in a place that has a repository for information, this gets more and more complex. So when you start to think about the outgoing web of partnerships that have to happen, that's why I say pretty soon it's apparent that it's a community problem. So if you take a map, let's say you want to take care of everybody who lives in the places that are orange, you got a bunch of hospitals, a bunch of home health agencies, skilled nursing facilities, assisted living facilities, many other provider types that are involved in the care continuum for the elderly. And then, of course, you have many, many, many people's homes and many people's homes. So that very quickly you can see that you really have to step back and start thinking about how can we form a community here for us to present a unified plan, a unified goal, and create some priority steps for unified action. And what we're wrestling with now within the communities is how can we be sure things are getting better. So the way the communities have approached it, there's been basically 4 different ways. Now there's many, many variations on this, obviously, and most communities are using some elements of each of these types of ways, but this is kind of the way I think about it. So in the upper left-hand corner, we have communities that have organized essentially as a group of paired partnerships based on the proportion transitions table. So if you can say, oh, look, here are the pairings that are leading to the most readmissions within our community. So we need this home health agency and this SNF to work together, and we need this SNF and this assisted living facility to work together. So there's a series of pairs that are working together with information sharing, kind of like a collaborative model type effort. In the lower left-hand corner, we have a number of communities that have done sort of a cluster arrangement within their larger community where they pair typically each hospital with their key partners, their key home health agencies and nursing homes, and often assisted living facilities, and have said, here we're going to support this type of improvement effort among this cluster, with the clusters kind of sharing as a collaborative model and then coming to community-wide data. In the upper right-hand corner, we have several communities that have felt that within their community they needed to ensure the participation of all the home health agencies together, all of the SNFs together, and all the hospitals together, and that they needed to work out their priorities within their setting type with the plan to integrate vertically as time goes on. And then we have a couple of communities that started out with, we're going to establish a community-based multi-setting steering committee that we're going to try to cede authority of managing this project to as quickly as possible. So as I said, most communities have elements of each of these going on. So within a couple of the communities, particularly the communities that are trying the whole global, we want the community to own this, we are getting very interested in the power of social network analysis to help map the relationships and highlight the areas where relationships either need to be created or to be improved. So in this map, this is obviously not a social network analysis of a care transitions community. This is just an example of what I mean by social network analysis. So Qualis Health in Washington and Bill Mahoney, who invented a lot of what we know about social network analysis, is kind of helping us think about how we could leverage a social network analysis approach to community building in the future, because it is so clear that when you start to work on transitional care and hospital readmission reduction, it just so quickly morphs into a community problem that I think the sooner we can become adept with community building techniques and data analytic techniques, the better. So in terms of our results, we have results kind of hot off the press, and I'm sorry I did not get them incorporated into the slide deck in time. So the first thing that we have learned as a result of all this work is in terms of how to measure readmission. So what we started out with, the aim of the project was to reduce the proportion of discharges that are readmissions, essentially. And this is the measure that's being most talked about in terms of national efforts to reduce unwanted hospital readmissions. But what we found in every case is that as communities work to reduce readmissions, they inevitably reduce admissions. So if you put admissions as the denominator of your measure, what we have found is that the proportion of readmissions can stay the same. It can even go up because the denominator in some communities has declined faster than the numerator. So, and it's just really kind of a built-in problem when you think about putting a timeline, which in this case is 30 days, on your numerator. So when we're looking at proportion of readmissions, that's proportion of readmissions within 30 days. So as communities have implemented these effective interventions, you know, a readmission at 32 days goes into the denominator, but a readmission at 29 days goes into both the numerator and the denominator. So it's clear to us that probably as this work goes on, we need to think about different ways of measuring the effectiveness of interventions designed to reduce readmission rates. So we have moved to experimenting with population-based measures of readmission, meaning number of readmissions per 1,000 beneficiaries in the community. And because CMS had the foresight to set this project up as a population-based project, we have been able to calculate that rate, and in general, every community within this program is experiencing a reduction in population-based readmission rates. And we hope to release official results around that very soon, hopefully within the next, I don't know, week or two. So when we have just looked at our communities compared to 56 other, you know, sort of similar communities, when we look at the readmission rates from 2007 compared to calendar year 2009, now these are different time intervals than the way the QIO projects are actually officially being evaluated, but just in looking at a first pass comparison between 2007 and 2009, when we look at the proportion readmitted, the intervention communities are making greater progress. When we look at the readmissions per 1,000, the intervention communities, again, are making like 3 times as much progress as what appears to be background. And the admissions per 1,000, meaning the reduction in admissions per 1,000, is double what has happened in other communities in which these interventions are not occurring. So we're very hopeful that this approach that has been taken through the theme is an effective way to address the problem of transitional care and unwanted hospital readmissions. All right, so in terms of the role of home health within the theme, I wanted to give just a couple of examples, and I'm sorry I didn't include actual data tables. So the first thing I wanted to talk about is going back to the proportion of transitions table. When we look at total transitions, meaning between senders and receivers, among any transition within the 14 communities, and this is counting the number of transitions within 30 days of a hospital discharge. We find that home health is a receiver among these 14 communities 9% of the time, and they are a sender 19% of the time. So home health agencies are a party to 19% of all transitions in 14 sort of typical communities. So certainly home health is quite a prominent participant that, you know, it's very desirable that we fully engage home health agencies in looking at the problem of improving transitional care and reducing unwanted readmissions. So the total transitions within our 14 communities is a little over 25,000. For the interventions, for active participants in the interventions as captured the communities in their data collection mechanisms, we have interventions directed at over 1,000 of these that are demonstrating improvements. So we have, for instance, one community in which the community aggregated the efforts of 28 home health agencies. They did root cause analyses among these 28 home health agencies and surveyed the home health workers. And this group of 28 together established a list of priorities of exactly what they felt needed to be solved by home health agencies in their community. I don't think that their results would surprise anyone. It has to do with standardizing communication protocols, implementing best practices such as properly engaging patients and families, implementing SBAR-type communications, a number of the things that are in the best practices intervention package. And together, these 28 agencies have demonstrated that they have reduced their readmission rates as they are implementing these interventions for patients that they receive, and this community has reduced the home health readmission rate by well over 2%. We have another community in which 8 home health agencies collectively implemented the pillars of the care transitions intervention, which is notation and resolution of medication discrepancies by patients after they get home, directed teaching around red flags for readmissions and who to call, direct support for contacting the appropriate follow-up care provider, and proper engagement of families in being assistance. And this home health this group of 8 home health agencies has reduced not only their acute care hospitalization rates, is going in the opposite direction from the other home health agencies in the state, but they have demonstrated that the primary hospital that they receive patients from has reduced its readmission rate by over 5%. Among heart failure patients as a result of home health agencies coming together and forming sort of a collective best practice package, sharing results and working collaboratively to get that done. So the 2 interventions I just talked about are, I think, being written up to be submitted for publication, and that's the reason I can't show their data right now. So hopefully that will be in the public domain within the next couple of months. So just to summarize, I want to give everybody a time to ask questions. So in the end, I always try to think about what would I recommend that a motivated home health agency do. And so I hope that I've indicated that to me there's tremendous strength by providers coming together to agree on best practices, to compete only on execution, not on what is the goal of best practices, and to understand the role of individual participants and the profession as a whole within the local system. So admittedly, this is greatly benefited by access to group community data, which has been a huge advantage of having Medicare encourage us to focus on this idea. My hope is that within the Medicare reform package, there will be many more opportunities to make aggregated community-based data available to community participants and to the public in general that can help support these kind of efforts. If nothing else, the power of root cause analysis among home health agencies working together is a common theme underlying success in the degree to which we can see home health contributing to a reduction in readmissions. I think there's absolutely an imperative to understand who your partners are, what your role is within your specific supply chain, and get together with those upstream and downstream providers and say, how is my process serving or not serving you? How is your process serving or not serving me? And what can we do to make this better? And then in the end, I would say I think home health agencies should be investing in transitions coaching. We have a lot of great evidence demonstrating that has been quite effective. So in summary, I forgot to tell you the results of our analysis of the role of home health within the readmission. So what we have found between calendar year 2007 and 2009 is that we are seeing a slight increase through these communities coming together and deciding what they want to work on. We're seeing a slight increase in referrals to home health and some notable decreases in readmissions resulting from home health agencies. So the increase over the 14 communities is about 0.5% of all transitions that are being discharged, of all discharges, going to home health. And we've seen about a 0.5% decrease in the readmission rates that are resulting from home health agencies. So we do think that home health is a key partner as this work goes forward, and I would love to answer your questions. So thank you.
Thanks, Jane. Before we go to questions for Jane, we now have Cynthia Pammon, who's our government task leader for the Home Health National Campaign, and I certainly wanted Cynthia to make a couple of comments. Cynthia.
Hi, everyone. I just wanted to thank Dr. Brock for that presentation and their work that they're doing in the 14 states, and the care transitions theme and the ninth scope of work is very important. I believe their government task leader, Tracy Archibald, is also on the phone, so we give her a lot of kudos and credit for that great work, as well as the work of Dr. Brock and her team at the QIL. So I just wanted to say that, and also just to let you all know that myself and the folks here at CMS are very proud to support this work, and I'm sure that the team at West Virginia, they will give you an opportunity to submit comments and questions or concerns after this presentation. And I would be interested in hearing from all of you all out there in the community. You know, what would work for you on the national level, or local level, the community level, and even in your agencies in terms of how we can make this process better as far as care transitions are concerned. You know, what are some of the ways that we can remove the barriers so that we can work on the community level, but how can we spread the good work that you all are doing out there across the nation? So I'm sure that Dave and the rest of the folks there at West Virginia will give you an opportunity to submit those ideas, and those are things that would come to me, and I would be actually interested in seeing how we can implement them. So Dave, I'll turn it back over to you.
Cynthia, thank you very much. And again, we're more than happy to answer those questions and further the collaboration that we're doing. At this point, we're ready for your questions. And again, just as a reminder, if you would please submit your questions to the following website, hhqi@wvmi.org. We'll take those questions, and I'm going to turn it over to Shannon now for the first question. Shannon?
Thank you so much, Dave. We're going to take our first question, which is from Deb, who asks for tips related to getting a hospital to align in the agency's mission to reduce avoidable acute care hospitalizations when they are not currently impacted by ACH. Dr. Brock?
So I think that the imperative for hospitals to reduce readmissions is hopefully going to create natural partnerships here. So I know we have this one very powerful example that I hope we can publish in the public domain soon that shows how 8 home health agencies working together to reduce their ACH rate has made a very significant impact on their primary hospitals' readmission rates. You know, they're just pretty tied. So I don't know where you're working, but I think hospitals are seeing the writing on the wall that if they need to reduce readmission rates, they need productive partnerships with people who can operate in people's homes.
Our next question comes from Mark, who asks, what background makes an ideal coach, nurses or others?
That's a great question. In the randomized controlled trials done by Dr. Coleman's team, and by the way, let me just give you his URL for his intervention. It's just www.caretransitions.org. So in the randomized controlled trials, nurses were used, RNs. Within the 14 communities, we're using a lot of different types of people to do coaching. So there are some that are using social workers. There are some that are using students that are making it part of student nursing curriculum, student medical school curriculum. There are a couple of communities where they are partnering with area agencies on aging, which I personally think is a very strong approach. The people who do other home-based services like senior transportation, home safety audits, meal delivery, nutrition support services. So I would say that the strength of nurses and other medical personnel is in terms of addressing the patient's confusion about medication or helping support patients to address their confusion about medications. However, there are other ways to think about this. So for instance, in the communities where they are using non-medically trained personnel, there's a real push to establish sort of a hotline to the hospital pharmacy or to another pharmacy where a pharmacist could actually do that part in real time as questions occur. So I think there's good methods being put into place where it does not have to be a medically trained person in the home. However, that does require, I think, a link with someone with confidence to assess whether or not the person has a dangerous confusion about their medication. So coaches are very different than caregivers, and in a lot of ways you want to choose folks who can coach, which is an important personal skill. So anyway, I hope that answers the question.
Our next question comes from James, who says, I feel like we need a lightning bolt to wake up our community. Any advice on how to do this?
Well, my hope is that there will be ways to publicly release Medicare data around hospital readmissions by community as part of what's coming up from CMS. I don't know yet. I know there's a lot of will to do that. So my hope is that if we could release, say, zip code defined, so defined by zip code of residence, rates of readmissions, that communities would look at that and say, wow, we have a problem right here. Short of that, I think a lot of the reform legislation it should be helpful to motivate people to get it together. You know, there's now attractions to forming accountable care organizations, to forming effective medical homes, to reducing unwanted readmissions, and ultimately on the horizon, you know, total cost of care within areas. I think within our communities, and I'm most familiar with the Colorado community, I wouldn't sell short just the will of communities to solve their own local problem. So I know we just basically released the fact that we were working on this to the community in a general community-wide meeting, and we got so much engagement, so many volunteers of help that it was, we almost didn't know what to do with it at first. But I would not sell short the fact that people who live and work in a place really want to make things better. And so we are increasingly looking at things like social network analysis and other sort of grassroots community building activities as a way to get people really motivated to form collective action structures that can take meaningful steps based on the priorities of their own local circumstances.
Our next question comes from Misty in Pennsylvania, who asks, what endeavors are occurring to improve physician knowledge of care transitions and the success of care transitions in the physician's role?
That's a great question. Most of the communities, and part of this has to do with the way our measures were structured, but I would say most of the communities worked for the first 18 months without significant engagement of physicians because it is so difficult to find a single place where you can engage, quote, physicians, unquote, you know, because they practice in small groups and they often are not available during the times when you can have group meetings and other activities. There's a lot of general education available. I know a number of the QIOs are working within medical societies, other medical associations, and in Colorado we have a lot of IPAs, and our IPAs, independent practice associations, have been extremely helpful for us to get to a place where there's a sort of a unified front of physicians to work with. I would say that we haven't solved that problem, honestly. And anybody who has great ideas, just email us.
Our next question comes from Teresa, who asks, how would community-based home health agencies engage discharge planners to encourage or solicit home health referrals so that home health can get in and do medication teaching and thus encourage compliance with the discharge plan?
So wait a minute, read that question again. How can community-based home health agencies?
engage discharge planners to encourage or solicit home health referral so that home health can get in and do med teaching and thus encourage compliance with the discharge plan?
So there's nothing more powerful, I think, than actually reviewing a couple of readmission cases. So certainly hospitals are being encouraged to do this. Certainly a home health agency that has readmitted to a hospital, I think, could promote the agenda that if we sat down and reviewed this case together, you know, maybe we could find some easily solved problems. So I think an attractive place to start is to invite other providers on whom you depend to review some mutual readmission cases and discuss what went wrong that can be fixed. Now, I would say within our projects, and I think there's also an enormous advantage to having home health agencies band together and say, we as a profession do this. We as a profession recognize these as best practices. And certainly that the BPIPs are really the backbone of getting that sort of thing started. Here's who we are. Here's what we believe in. Here's what we are trying to do. How can we incorporate the profession of home health better into your discharge planning and into your discharge practices? I think where things kind of fall apart is when you have so many receiver competitors competing for market share, so that the central message of here's who we are and what we do and what we can do for you kind of gets lost. So I would encourage home health agencies to band together to present a unified front for this is what home health does.
Our next question asks, are you using a standardized tool for red flag alerts, something like the stoplight tool, zones for management as an intervention on discharge? This writer says that these have been very effective for them and their agency.
Some of our communities are using those, yes. I also think this is the kind of thing that is ripe for local standardization. In terms of red flag teaching within the care transitions intervention, there's you know, recommended methods for doing that. But no, I think local standardization of tools is probably powerful. I guess we don't have the data to really assess that within the 14 communities. So anyway, I would encourage you to go forward. And for instance, that's a perfect thing that home health agencies could unify around as here's the product we deliver. So if some are using it, it's not nationally standard.
Okay.
Yes, sorry.
Our next question comes from Shannon, who asks, do you know the dollar amount associated with a 0.5% decrease in readmissions across the 14 communities?
Not off the top of my head, but we could certainly get that to you. So here's what I think I would like to do. Let me just make myself a note. We will send the numbers that we have of the role of home health and the change in home health through the care transitions theme between 2007 and 2009, the numbers I just said orally. And we can try to assign average cost savings and the method we use to calculate that. We can send it to the HHQI folks who maybe can then make it available. Would that be reasonable?
I think that sounds great. Our next question is from Janet, who asks, can you describe an accountable care organization, or ACO?
Oh, heavens. Well, there's a number of definitions of that, but if you're looking for a specific definition, I can find one. My personal opinion is we don't exactly have a single standard definition, but it is supposed to be a mechanism for providers to agree on mutual accountability around care patterns, quality, as well as cost constraint, and to prepare them to share savings.
Okay, our next question comes from Linda, who asks, when will we be able to see the data of the successful relationships in existence now that we can offer to area hospitals? Being able to cite actual case experience would help us. Thank you for your presentation.
Let's see, the question is when? I think within the next 6 weeks, 6 to 8 weeks. we hope to have a number of case examples ready for publication.
Carolyn asks, are there other studies done for nurses versus non-nurses as far as the coaching role? With all the medication problems like polypharmacy, adverse events, et cetera, it seems like having a nurse as a coach is really essential. I know you already mentioned this, but I'm curious that if there are other studies supporting the nurse role as a coach.
No, so I would say the published evidence around transitions coaching supports the role for nurses, in that the randomized controlled trials that led to the establishment of the care transitions intervention as an evidence-based intervention used RNs. I know among the RNs that we use, they're more confident coaches from the get-go. I think there's a lot of evidence to suggest that nurses are very good in that role.
Our next question comes from Joan, who says, I received a call recruiting to become a transitions coach in Indianapolis from a private insurer. This surprised me to see insurers driving this process. I thought hospitals would be managing this. What are your thoughts on this?
Well, insurers, so the payers are the ones that stand to save the money from reducing readmission. So it doesn't surprise me that many payers are interested in the role of transitions coaches. Part of the reason behind trying to reduce compensation to hospitals for readmissions was to create a financial incentive for hospitals to invest in coaching as well. So I think within the Medicare reform package, there are a number of mechanisms whereby I believe it's likely that Medicare is going to be directly encouraging such things as coaching as a payer of hospital services as well. So it doesn't surprise me that payers are investing in this model on a large scale. My only concern is, we may have gone from, sort of a dark ages where nobody even knew what a transitions coach was to every discharged patient having, 4 coaches. Which again draws me back to I would encourage any elements around community-based action to be put into place right away. I mean, we could hammer people to death with coaching. So anyway, I think many participants along the spectrum of care are very interested in coaching patients. I think home health, though, has such a unique advantage in that home health agencies employ people who aren't uncomfortable with the thought of going to people's homes. And, you can't say that about all provider types. So I think home health agencies should be preparing themselves to accept this role.
Our next question comes from Linda, who asks, have you seen any correlations between the use of hospitalists and the disconnect for patients discharged to home when a patient's personal physician has not been involved in the patient's hospital episode?
I think that is the disconnect that we see a lot in these readmission numbers. Yes, the role for physicians there very clearly is a role for physicians. The problem is if physicians are not paid to do hospital visits and or they don't even, increasingly you don't see primary care physicians even retaining, hospital privileges because they're quite busy and they're quite overwhelmed practicing in their own office within the outpatient setting. Certainly, I would encourage you to look at people who are interested primarily in the role of hospitalist to primary care physician interaction. I would encourage you to look at Project Boost. That's the Society of Hospital Medicine's, really it's a whole well-designed quality improvement package. It has online data collection tools. It has lots of great suggestions for how hospitals engaged in Project Boost, how hospitalists are incorporating their role towards their primary care physicians and how primary care physicians are responding to it in order to build, reliable bridges for information between hospitalists and primary care physicians. I think it's quite a promising intervention package.
Christopher asks, what role has telehealth monitoring played in the positive results?
Great question. I would say we need to assess that. I don't know that right now. We hear a lot that the home health agencies that are actively participating within the QIO projects are implementing telehealth and are interested in implementing telehealth. And I'm aware of early results of telehealth showing really promising results. Within our projects right now, I can't tease out the separate impact of telehealth within our data, but it's a great idea, and we should think about how we can do that. So anyway, thanks for the suggestion.
Mark asks, how many coaching visits or hours are typically used in the average home health episode?
In the average home health episode, well, transitions coaching is not a paid function right now for home health. I think there are likely to be many home health workers who do intuitive coaching, who maybe do intentional and directed coaching. The care transitions intervention it usually involves the home visit is about an hour to an hour and a half, sort of depending on the debility of the patient, their degree of sort of natural activation, and the complexity of the management problem. So the home visit by the coach is about an hour and a half. And then the follow-up phone calls are often quite a bit more brief. So maybe I should say that the care transitions intervention is a 5-contact intervention where the coach meets the patient in the hospital, does a home-based visit, a lot of which is around proper notation of medication discrepancies within 2 days of discharge, and then 3 follow-up phone calls. So the total time invested per patient by a coach is somewhere around, 4 or 5 hours. It depends, obviously, on driving time and that sort of thing.
Our next question is also from Mark, who says, we have discussed care transitions interventions with various physicians, but the physicians do not seem to understand the concept. He'd like to know if this is a local issue for his agency, or is this something that you see nationally?
Yes, you see this nationally. It's not a local. It's not a local thing. Yeah, believe me, this is quite a common response. People, so medical services providers are so focused on their part of the care trajectory and their responsibility to recommend to people what they do to maintain their health that I think they lose sight of, or in fact, at first blush, just don't believe that people can be activated to self-manage. I mean, I think there really is an ambivalence about the degree to which self-management can be effective. So I would encourage everybody who has these kind of questions to go to Dr. Coleman's website, caretransitions.org, and read some of these case studies. Certainly, we hope to have numbers around the effectiveness of the CTI itself as an intervention within the care transitions theme, and it's just in every community it is being effective. People truly can be activated, and I don't know whether maybe just more presentation of evidence would be helpful as a product from this from the care transitions theme. But yes, I would say that's standard, that at first medical services providers just don't believe. So I don't know, keep preaching. Go ahead.
Sorry. Next question comes to us from Monica, who asks, what is the % of hospital admissions that get discharged to home health before the study, and then the average after the study?
Okay, so this is not really a study, just to be clear. This is an initiative to change care patterns within 14 communities. So the numbers that we have, let's see, in 2005, among our 14 communities, in 2005, 17.9% were discharged to home health. And in 2009, that number was 18.4%. So that's a 5% change. Does that answer the question?
Yes. Moving on to our next question from Gary, who says that he agrees with the presentation that partnerships can be challenging. Forming a community of providers is a great approach. He'd like to know if there are any resources to share with what a community is, and explains why we should work together on transitions, specifically something that he could share with the providers in his community.
an actual resource to do this. You know, I don't know of a single resource that I can just whip out off the top of my head. So a lot of our work in this was informed by study of the Grand Junction market, and we did just publish that in Health Affairs, how we came to this understanding that community-based collective action is the way to go. So that was published just a couple of weeks ago in the September issue of Health Affairs, and the title starts with Grand Junction. So I would encourage you to read that and think about how some of these just basic elements of vision for a community that serves a finite population of people could be promoted within your location. I also would encourage you to read about social network analysis and or communicate with Qualis Health. Sorry, Qualis, if you're on this call and don't agree with this, but who's really doing some interesting groundbreaking work on trying to bring these analytic techniques to care patterns and utilization patterns using Medicare data, and to think about how that could perhaps be applied to your community. So that's my best answer kind of off the top of my head. But yeah, thanks for the question. We're trying to develop this body of work ourselves. We didn't think that we were starting out to become community organizers, but now it's very clear to me in healthcare quality we need to learn and learn fast from people who do community organizing.
We have time for 2 more quick questions and 1 comment. The first question is, have you looked at readmissions of patients who were eligible at the time of discharge for home health but did not receive it? Do physicians and discharge planners need education on qualifications for home health? Do you think this is an issue?
Yes, I very much think this is an issue. We don't have data specifically around that. There are a number of the local projects who are doing directed teaching to not just discharge planners, but to others along the continuum of care about what is the real definition of homebound. I would say that's a huge stumbling block, and there's a lot of misunderstanding about that. There's actually evidence there's misunderstanding about that within home health agencies and among home health workers as well. So there was an AHRQ study done that was led by Mike Silver at Health Insight, which is the QIO in Utah and Nevada, that shows that absolutely this misunderstanding of what home health does is a huge stumbling block for referrals, and that there are intervention tools that can help you with that. So let me see if we can get that information out to you guys also. But yes, many of the QIOs and their community partners are looking at ways to dispel myths around home health, what home health does and does not do, and to incorporate appropriate referrals to home health as part of a community standard of care. But again, this gets me back to, I think home health agencies can be very powerful when they present themselves as a unified front, as opposed to this agency is trying to get this kind of patient and that agency is trying to get this other kind of patient. I think that confuses everybody.
We've had several questions asking us for your website address again. And what is that address?
Oh, it's www.cfmc.org/care transitions.
And to wrap things up, we have 1 comment from Jeff who says, I appreciate your information and we do need to work together as a community. He really thinks this is great information and feels that as home health agencies that we all need to band together and put patient care as our top priority. What are your thoughts on this?
I couldn't agree more. And I understand so saying that is very simple, and I understand there's a lot of devil in that detail. But yeah, I would encourage you all to get back to us on what you think would be the most successful approaches for us to help move that trend along, and for us to maybe be helpful to you all in trying to energize your communities to get behind this idea.
Thank you so much, Dr. Brock. We're going to toss things back to Dave Winter now for today's closing remarks. Dave?
Jane, on behalf of myself and the rest of the Home Health National Campaign team, as well as the participants on this call, we really would like to thank you for this very informative and valuable presentation. Again, we'd like to encourage all the participants to, again, visit our website for the national campaign. That is, again, www.homehealthquality.org. And as a reminder, Dr. Brock's talk and her slides are being archived and will be available on our website by this coming Friday. So please, for those of your colleagues that were unable to participate on the call today, please give them that information that they can download Dr. Brock's presentation, including her slides. Just as an FYI to all of the folks on the call, our next webinar is scheduled for November the 12th at 12 noon Eastern Time. The title of that webinar will be Making Care Transitions a Reality Through Home Health. And a couple of the objectives of that talk are really to share best practices on the development and the launching of a home health-based care transition initiative related to coaching. So I think that this really sort of takes off from some of the groundbreaking, very, very cutting-edge work that Dr. Brock and her team and the other 14 states are working on. Again, we want to thank everybody for being on the call today, and hopefully everybody will have a good day. And again, if there are any questions, please shoot us an email at hhqi@wvmi.org. And again, Dr. Brock, Jane, thanks ever so much for your time and this valuable information.
Thank you very much for the opportunity. Bye-bye.